class today.
Okay, why don't we get started? Most of you probably know Derek quite well. Derek Chu was one of our cardiology and then electrophysiology fellows. He really distinguished himself when he was here. He, besides being an excellent clinician and getting, I think, general accolades for that, he devoted a fair bit of time to research with several of us, and ultimately decided to pursue further academic training. During his electrophysiology fellowship, he actually concurrently did a master's in health economics at the London School of Economics, where he graduated with distinction. And since leaving us a little over a year ago, he went down to do a formal fellowship in health economics at Duke University in the Clinical Research Institute. In order to fund that, he actually received a very prestigious CIHR Banting postdoctoral fellowship in recognition of both his accomplishments and his high potential. So right now, Derek is working at the Duke satellite office in Vancouver due to COVID, but still being quite productive. We are hoping that we're going to be able to get Derek to come back and join our group and really bring a new aspect, I guess, of research that we don't currently have, which is really a focus on health economics to inform what we do going forward. With that, let me introduce Derek and let him tell us how we're going to apply health economics to optimize the care we deliver. Derek?
Well, thanks, Satish, so much for that kind introduction. And thank you for the opportunity to come here to present to everyone about some of my research interests and some of my research activities over the last couple of years. My disclosure slide, just thanks to my salary support from the Banting Postdoctoral Award, as well as the Arthur Child Fellowship for funding my master's, and a small internal grant from DCRI to talk about some of the research that I'll be sharing with you today. Now, when people drop the term health economics, you may or may not think of health technology assessment, cost-effective cost utility analyses, but really health economics is a much more broad field than that. And it includes research looking at improving system efficiency. That might be optimizing patient care pathways or measuring quality of care. And this is the approach I've been taking toward my research. So over the next half hour to 40 minutes, we'll cover some examples in each of these facets of health economics. And more specifically, here is the summary of my presentation and what we'll be covering. So we'll first start talking about economic evaluation, cost-effective analyses for various cardiovascular therapies, and we'll see how it can be applied to the cardiovascular landscape, and we'll talk about some caveats to economic evaluation. And then the second half of my talk will focus on improving system efficiency, which is just as important as economic evaluation, if not even more important. And within that purview, we'll talk about measuring quality of care, adherence to best practice, and optimizing patient care delivery pathways, which are two related concepts under the purview of system efficiency. Now, before we jump into that, let's briefly talk about some health economic jargon that I'll be stating quite a bit in this talk. So the first thing you may hear of the term Markov model. It's one of several methodologies in economic evaluation, and it's less complicated than it actually sounds. So let's take an example of heart failure. So Markov model takes a hypothetical cohort of patients, and these patients can live in a mild symptom class, NYHA class 1 or 2, or a more severe symptom class, NYHA class 3 or 4. And what the Markov model does is it allows patients to transition between these health states with certain probabilities defined by inputs from the published literature or some external data source. And what the Markov model does is over a given time period, let's say every year or annual cycle, the Markov model moves these patients between the various health states, and it accrues their total clinical outcomes, the total costs, their quality of life that they experience, until everyone's cycled through this model and dies off. And depending on the disease state, this Markov model can run from anywhere between months to years to decades. And the whole point of this Markov model is to obtain something called the incremental cost effectiveness ratio. This is the outcome called the ICER, and it's simply the difference in total costs, so between a new therapy or some therapy and a comparator, often standard of care, balanced by the difference in outcomes between the two strategy. And this is valued in a dollar amount per quality adjusted life year gained, or quality adjusted life expectancy. I like to point out that this research I'm presenting, like any other research, it's a team approach and requires a multidisciplinary team. Most recently, I've had the opportunity to work down at the Duke Clinical Research Institute with Dan Mark, who's one of the world's preeminent health economists in the cardiovascular area. Had the opportunity to work with him, his team, my mentors in the University of Calgary, Derek, Ray, and Satish, and many, many others. The point being is the research that I'll be presenting here today isn't just mine, but also the work of my many collaborators. It comes as no surprise to many of you that healthcare expenditures are on the rise, and a growing proportion of Canada's GDP is being spent on health. And clearly this is not sustainable. So the question becomes, how do we control costs? Now, we could do this one of two ways. One, we could just simply stop spending, which has its disadvantages. Or the second option is we could spend more efficiently and work with what we have. And this is the beauty of health economics. It provides the tool set and the methodologies to both assess and optimize healthcare and allow us to spend more efficiently. Now, this isn't some issue just faced by government workers and policymakers. This is something that we face every day as clinicians taking care of patients. We're torn between providing the best care possible for our patients. In the back of our mind, we do need to control costs because ultimately we want to ensure a sustainable healthcare system for future generations to come. Now, I'd like to make the point that the term cost effective does not mean that a therapy is inexpensive. When you spend on, let's say, therapy A, that means there's less money in the pot to go around for therapies B, C, or D. There's an opportunity cost to everything. So how do we value, or how do we judge good value for money? Well, traditionally we use a threshold of $50,000 per quality adjusted life year or quality gained. And this is historically based on the cost of providing dialysis. And you might argue if that's the appropriate threshold or not. Some people argue for a higher threshold of 100,000 per quality gained. And this is a bit country specific too, where in the US, some people gauge things with a threshold of 150,000 per quality gained. So I'd like you to remember these thresholds when we go over some of the examples of some cost utility analyses. Let's dive into some examples of economic evaluation. And so we have this problem of device infection, and it's a big deal. It occurs in 1% of all device implantations. And not only is it associated with significantly increased morbidity, mortality for our patients, but infection comes at an increased cost of approximately $92,000 for one device infection. Now, there are innovative ways to try and reduce device infection, including something called the TYRX pouch, or an antimicrobial pouch. And we do have randomized controlled trial evidence that it reduces the risk of major infection by a relative risk of 40%. The problem with the antimicrobial pouch is that it's not inexpensive. And in fact, the TYRX pouch costs more than a single chamber pacemaker plus lead. So if we were to apply this in a quarter of all device implantations in Calgary, in the Department of Cardiac Sciences, we need to increase our budget by over $500,000. We'd be doubling the cost of a pacemaker implantation, which is silly. This is not feasible, not realistic. So now the question becomes, what exactly is the cost effectiveness of the TYRX pouch? And are there certain subgroups within the general device population that may benefit from an economic and clinical standpoint? So we designed this Markov model, connected to economic value, into the Markov models like I spoke to you all earlier. And we compared the antimicrobial envelope to standard of care. Here are the outcomes in this Markov model below. And we used inputs from the literature and the RAPID trial to inform the model. And that included an infection risk of 1 year of 1.2%, which is roughly the infection risk in Calgary. I mentioned the cost of the TYRX pouch earlier, and we took the perspective of the Canadian healthcare system. Bottom line from this analysis is that the incremental cost effectiveness ratio was 3.6 million per quality gained. That far exceeds any of those thresholds for good value for money that I mentioned previously, threshold of 50,000 to 150,000. So, is this our answer, that we can't implant TYRX in anyone? Well, no, this isn't the answer we're going for. We were more interested in which subgroup where the TYRX pouch may be more economically attractive and perhaps represent good value for money. And when we did this analysis, what we did was we compared the base risk of infection with standard of care, and we compared it with the cost of the antimicrobial pouch, and to generate this figure here. And what this figure shows is that when the infection risk, the base infection risk is pretty low, I'll say low of 2%, for the antimicrobial pouch to be economically reasonable or good value for money, it would need to be priced at $500. When there's a base infection risk of 10%, we could tolerate a cost of upwards of $2,000 for the TYRX pouch. But at current pricing for this pouch, the base infection risk would need to be greater than 6%. Now, does this happen in clinical practice? Well, yes, it does. There are patients at high risk of device infection. And who are these people? Well, people on hemodialysis, they're exceedingly high risk of device infection. People who require multiple device surgeries, often greater than 3 pocket reinterventions, and those who've had prior device infection. So here's an example of a technology that's relatively expensive, but using cost effectiveness analysis, economic evaluation, we can identify a high risk group of patients that would benefit most from this from an economic and clinical standpoint. Why don't we shift gears and talk about another type of therapy in the realm of electrophysiology, and that's catheter ablation for atrial fibrillation, specifically when it comes to heart failure patients. Now, there was this modest-sized clinical trial, CASTLE-AF, and bottom line is that this clinical trial has been very controversial, where there's been a lot of criticisms regarding the methodology, and we'll get into why people believe this trial is too good to be true. But what this trial did find, it's a randomized controlled trial, it found this remarkable benefit, an absolute risk reduction of 12%, which is quite remarkable at 5 years, in favor of catheter ablation compared to medical therapy. And so it comes as no surprise when you put this in a Markov model that the ICER, the incremental cost effectiveness ratio that we achieve, catheter ablation is good value for money. The ICER is 38,000 per quality gained. And that's below our threshold of $50,000 per quality gained. So does this mean we should be, doubling our EP lab space, ablating everyone with heart failure with reduced ejection fraction? Well, the one caveat, as I alluded to, is there's been a healthy dose of skepticism when trying to believe the CASTLE-AF trial. And some criticisms of this trial, there were a high proportion of participants lost to follow-up. There was an unusual approach to how they standardized heart failure therapy prior to randomization. And bottom line, it was a very, very highly selected population. I bring this example up just to highlight the point that just because someone's done a cost-effective cost-utility analysis doesn't mean that we should live or die by the ICER, that this isn't the truth. That the quality of inputs matters as well as the design of the markup model. Now, let's compare that to another therapy, left ventricular assist device for destination therapy, or LVADs, in patients with end-stage heart failure who really have no other option. They aren't candidates for transplantation. And here are the two pivotal landmark randomized clinical trials. And unlike these clinical trials, unlike the previous clinical trial that I showed you, the CASLEF trial, no one's going to argue that LVADs aren't life-saving. There's an absolute risk reduction of greater than 55% when it comes to mortality. LVADs are life-saving therapy. But when we put this through our cost effectiveness analysis, our Markov model, the incremental cost effectiveness ratio is $230,000 per quality gained, which exceeds most thresholds for good value for money. So does this mean that we shouldn't be implanting LVADs for destination therapy? Does this mean that we shouldn't be offering this life-saving therapy in patients without any other option? Well, no, that's ridiculous. And the point with this is there's more to health economics and decision-making than cost-effectiveness analyses, in that things like social value judgments, things that society values, such as life-saving therapy and the opportunity for life, matters when it comes to health policy decisions. Now, does this mean that ICER and cost effectiveness analyses are useless? Well, no. It's still an important summary measure that incorporates clinical effectiveness, projected costs, as well as quality of life. So why don't we shift gears? And for the last half of my talk, I'll discuss this other area of health economics, looking at
masks
and efficiency.
Why do I have a mask?
Quality of care.
Steve, you need to mute.
So this area of research falls under the premise that there's practice variation everywhere. Usually it's unwanted, except when it comes to the Oilers playing the Flames. This picture's for Dr. Mitchell here, but seriously, with healthcare delivery, we don't want a huge practice variation. It can result in adverse patient outcomes. For example, people should be following guidelines. Adverse outcomes occur when there's variation in practice and people don't follow guidelines. Now, Derek Exner and I did this study a few years ago now, looking at repeat assessments of left ventricular ejection fraction in patients who are survivors of myocardial infarction. And, this is in the guidelines, the most recently updated device guidelines in Canada, as well as some of the older American ACS guidelines. And we were interested in clinical practice and how often people actually adhered to these guidelines and reassessed LV function post-myocardial infarction. And we used the approach database, which everyone's familiar with. And we did the study called the Acute Myocardial Infarction Quality Assurance Project, or AMICA, in 2 phases. And the first phase really was asking, what's current clinical practice? How often do clinicians order repeat left ventricular ejection fraction in the post-MI period? And phase 2 was really asking the question, all right, so we've reassessed LV function. Does it actually matter? So phase 1, we found 3,000 patients with myocardial infarction. Approximately 10% of those had some evidence of impaired ejection fraction. And we were really surprised that only less than 50% had their LV function reassessed in the post-myocardial infarction period. That is, less than 50% had guideline recommended LV function reassessment. Now you might say, well, maybe this is just good clinical judgment. This is just judicious use of LV imaging resources. But we took all these patients and we followed them prospectively and looked at if their ejection fraction recovered from the post-MI period in the long term. And what we found was that, this solid blue line, there was a group of patients who underwent adverse remodeling where their ejection fraction did not improve or in fact declined. And these patients were at a 3-fold increased risk for death and a 5-fold increased risk for sudden cardiac arrest. So reassessing LV function does matter because it can identify a really high risk group of patients where they might benefit from further optimization of LV enhancement therapies or potential referral for device surgery. Now, the cool part about this project is that it led to a change in the care pathway where, based on this work, patients in Calgary with some evidence of impaired LV dysfunction undergo protocol-driven LV function reassessment. And this work hasn't stopped here. So-called AMCA Phase 3 has been funded by the Canadian Arrhythmia Network of Canada and led by Dr. Steve Wilton here, Dr. Manluku in London, and Dr. Bennett in Vancouver. And Canada has funded this project and rolled it on a national scale to see if this approach can improve outcomes in survivors of myocardial infarction. Another area of great interest is how we deliver the care for atrial fibrillation. And this is a recent project that I've been working on with Braden Mans, Amity Quinn, and Flora Au. What we did was we found patients using administrative data in Alberta with new onset atrial fibrillation, and approximately half of those were at high risk of stroke. And we were interested in their quality of care and some various quality metrics, such as anticoagulation at 1 year's time and some other clinical outcomes. And we obtained data from Alberta Health Services to divide the province into various regions to compare the quality of care across the province. And what was very disappointing, again, was that the overall proportion of people who were started on anticoagulation within a year of diagnosis was quite low. And remember, this is a high stroke risk group of people. CHAD's 2 score greater than 2, age greater than 75. And approximately 45% of these people did not have guideline indicated anticoagulation. And for whatever reason, some people might not choose to go on anticoagulation. There might be other contraindications to anticoagulation, but 45% seems like a lot. So what this told us was, there's a problem in the quality of how we deliver AF care. And what may or may not surprise you is that when we looked at the distribution of how AF care was delivered across the province when it came to anticoagulation, some regions in the province were high performers and some regions were grossly undertreating their AF patients. And unfortunately, lower rates of anticoagulation occurred in more northern, more rural regions of Alberta. And what's more unfortunate is that often in these regions, a higher proportion of individuals self-identified as First Nations or Aboriginal. So what this tells us is that not only is there a problem in the quality of AF care in Alberta, but there's a problem with the equity of how we deliver AF care. Now, this is all preliminary work, and a lot more work needs to be done in this area, and we're just starting the projects to delve into this more. Now, what exactly needs to be done? Well, we need to better understand what's causing this variation. What are the determinants of practice variation across the province? Is it at the patient level? Is it at the provider level? Or is this a bigger health system issue or some combination of these different factors? We want to understand economic consequences of this healthcare variation. And finally, and most importantly, we want to develop strategies and study these strategies to reduce practice care variation to improve the quality and equity of AF care across the province. Now, I'd like to end on, this last theme of optimizing patient care delivery pathways. And it comes as no surprise to many of you that the time a patient waits for cardiovascular procedures, such as in cardiac surgery, has an adverse impact on patient outcomes. And as I mentioned, this is well known in the cardiac surgical world. And in fact, this is a metric, cabbage wait times, that AHS uses to gauge the quality of a hospital and quality of a healthcare system. Now, what you might not know is that wait times could potentially have an adverse impact on the outcomes of other cardiovascular procedures, such as catheter ablation, which we spoke about earlier today. And the premise behind this is that the longer the time you wait between first AF diagnosis to some definitive rhythm control strategy, such as catheter ablation, the longer the time that the left atrium can maladaptively remodel. And the longer we wait, the more remodeling that occurs, the less responsive that the atrium will be to catheter ablation. And we were interested in looking at this concept called diagnosis to ablation time and testing out the association with post-ablation outcomes. And we did this first by conducting a systematic review and meta-analysis. This is the forest plot here summarizing the observational studies looking at diagnosis to ablation time and the outcome of AF recurrence and adverse outcomes. And we see that in patients who've had shorter diagnosis to ablation times or shorter waiting time to ablation, they had a 27% relative risk reduction in procedural failure. We took this and expanded, we looked at this question in a larger data set of 11,000 AF patients, and we found similar results. Now, the hazard ratio here is reversed because we flipped the comparison. We're comparing diagnosis to ablation time greater than 1 year versus less than 1 year. And we see that when we stratify diagnosis to ablation time as a dichotomous outcome, we see a 28% relative increase in the risk of AF recurrence. So for every 1 year increase in diagnosis to ablation time, your risk of AF recurrence increases. And what we found remarkable was that DAT was a stronger predictor of AF recurrence than traditional clinical risk factors that we measure. And not by a little, but by a lot. Now, this is some interesting food for thought, since once a person's identified for a procedure, we should be following patient care pathways and putting in the resources and time to try and do everything that we can to shorten these wait times and optimize these patient care pathways, because wait times for ablation, they actually may matter. Now, delving more into the stroke care pathway, this is some work that I've been doing for my master's thesis, and stroke's a big problem. 5,000 Albertans have a stroke every year. And unfortunately, in approximately a third, we just don't really know what causes it. 30% are labeled as cryptogenic strokes. And of those cryptogenic strokes, a certain proportion, approximately a third, are thought to be due to hidden, undiagnosed, or occult paroxysmal atrial fibrillation. And this is a diagnostic challenge, since AFib is often intermittent. It's asymptomatic. Patients can't tell us if they're in it or not. And current standard of care with Holter monitoring is too short a duration of rhythm monitoring to be of any substantial use. Fortunately, there are longer monitoring strategies, such as the cardiac event monitor, which can monitor a person from anywhere between 14 to 30 days. Or you could put in a loop recorder, which can monitor your patient for approximately 3 years. And as you can imagine, the longer you monitor a person, you can vastly increase their AF detection rates. But this is balanced by increased costs with greater AF detection. So we were interested in the choice between 3 different patient care pathways: Holter monitoring, cardiac event monitoring, and loop recorder. On one hand, you have vast, different detection rates. On the other hand, you have increased costs. So we were interested in the cost effectiveness of these 3 different patient care pathways. And we did this again with a decision analysis and Markov model, where we compared those 3 detection strategies in patients with cryptogenic stroke. We made certain assumptions regarding their anticoagulation, depending on if they had diagnosed or undiagnosed atrial fibrillation. And these are the outcomes down here that we were interested in. This slide is just to show you that our model predicted AF like we expected. So the solid line is our predicted AF detection rates up to 3 years by the model. And we compared that with the AF detection rates from randomized controlled trials, and that's shown in the dotted triangles and solid circles. And we can see that our model actually tracks really nicely with the randomized control trial published rates. So our model was doing what we wanted it to do. And, it was a bit surprising that, the loop recorder is pretty expensive, but given that it has really, really high detection rates, it represented good value for money. The ICER was $41,000 per quality gained. And in fact, it was more economically attractive than the 30-day cardiac event monitor. So ending on that, that's, this is another example of health economics and how it can be applied to helping make us, the clinician, giving us the tools to help us figure out which is the best patient care pathway, in this case, how to best manage cryptogenic stroke. So that brings us full circle to the various aspects of health economics. We've talked about economic evaluation of new therapies, new technologies, how to judge good value for money, as well as some of the caveats towards economic evaluation. We've talked about optimizing and improving system inefficiencies through patient care pathways and gauging and measuring quality of care and how it varies across the province. And before I end, I'd just like to go back to something that I alluded to about how when it comes to economic modeling, the quality of inputs really, really matters. And I think this is where Alberta has the potential to be a leader in the field of conducting real world economic analyses, because Alberta has this rich data set of administrative data, including a world-class health costing system that's not really available in many provinces in Canada. And so, this is what excites me about coming back to Calgary, is that I have access to a living health economics lab. And I'd really love to do something and create something new within this research ecosystem. We could call it, the Economics and Cardiovascular Health Outcomes, or ECHO project. And some things I'd love to do would be continue my work in atrial fibrillation, looking at wait times, care pathways, quality metrics, and anticoagulation. There is a whole breadth of opportunities in the heart failure realm, some stuff that I didn't talk about today, but I've been collaborating with the heart failure group, looking at care pathways regarding Entresto initiation. And actually we found that it was more cost effective to start Entresto right up front rather than wait our typical delays before starting Entresto later downstream. So it'd be really interesting to expand this and see the economic implications and implications on outcomes across the province. There's a whole host of opportunities within the cardiac surgical interventional realm. There are a lot of therapies that are expensive that may or may not be good value for money. And it'd be great to look at the cost effectiveness of emerging techniques such as minimally invasive valve replacement therapies, hybrid revascularization techniques. There are opportunities to work with, elsewhere in the university with small startups to provide their economic piece at the Impact Clinical Trials Accelerator. And there are a lot of smart people at the Center for Health Informatics, Alberta Real World Evidence Consortium. There is an infrastructure in Alberta that I'd love to tap into, work with these smart people, put our heads together, do some innovative projects, and really do some really transformative work in Alberta. With that, thank you so much for listening to my talk, and I'm more than happy to answer any questions.
So Derek, that was great. So most of the health economic work that you alluded to seems to focus on the impact based on sort of incremental cost effectiveness, but obviously something can be cost effective, and if it affects a lot of people, it becomes just really expensive. You are no doubt aware that the economy hasn't been kind to Alberta. I don't know if you want to comment on the issues around sort of global impact as well as individual impact.
Yeah, so we've been talking about how to best gauge good value for money. I mean, when you, like you alluded to, being good value for money doesn't mean that things are inexpensive. And when you consider the underlying patient population that these therapies are applied to, the budgets can certainly balloon. But we need to start somewhere. One of the things I think you're leading to is talking about how do we fully control costs or potentially decrease costs. And this kind of relates to my second aspect of my research, looking at system inefficiencies, and that's where it relates is there's a huge amount of waste in Alberta, in the country, where based on practice variation, people underuse therapies like the anticoagulation example I gave, which has a huge downstream impact on future costs, such as rehospitalizations for stroke and increased death. And on the flip side, there is practice variation where people overuse low value therapies, such as preoperative testing for preoperative ischemic testing. So I think, as a whole, to best optimize and make sure that our system's sustainable, one, we need to have a metric whenever we adopt new therapies to make sure that we're actually getting the most bang for our buck, realizing that very few therapies in the cardiovascular sphere are cost savings, and that will be adding costs by adopting new things. But at the same time, looking at how we practice our care, identifying areas of waste, trying to cut back on that waste to save money where, it really, we shouldn't be offering low value therapies to patients. And using, that cost savings and reinvesting in these innovative technologies that are good value for money.
Derek, that was you're muted, Satish.
No, go ahead, Carlos. I was just going to open it up to others to ask questions.
No, that was a great presentation, and there's lots of things that we need to look into. As you know, choosing wisely would be something that would be very interested in looking at the value of health economics and decision making there. Now, one thing is that you do talk about a lot of the impact that these analyses can do. For example, your stroke analysis with the loop recorder. But my question would be, can't these analyses also trigger us to try to drive the prices of these technologies down?
Absolutely, and that's the model that the UK has taken, NICE, where before they link health technology assessment into their pricing. So before a company can, before the UK is willing to pay for something, the company has to demonstrate good value, and they link pricing to that. Unfortunately, in Canada, we don't do that. There are some really smart people at CADITH that, do health technology assessment, but because of the way that healthcare is delivered provincially, we don't actually link that in with price.
But I mean, we could do it at the provincial level. For example, in devices, we have it's a single RFP for the entire province. Why would a link cost $4,000? Even though you already showed that there's a pretty good, ICER there of around $40,000, it would be even nicer if the device cost $2,000. And actually, we could actually increment the type of population and the number of population that we can offer these devices at an ICER of 20,000.
Did you just say nicer ICER?
Nicer ICER, yeah.
Absolutely, and I think that's something that we should be moving toward, to be able to linking value to pricing. And if there's a motivation at the provincial level, that's something I think would benefit us for
I think the motivation is the data. We have the data. You guys have done some very interesting analysis there. I think the next step is to try to promote that kind of approach. It's not going to be easy, but I think that, it's a win-win situation for anyone, even for industry, because it's going to mean more devices, anyways. Now, other questions is, it's interesting, some of the analysis you showed on AFib. On the one hand, you're not that warm about AFib with heart failure, although there's some more data coming up. You only looked at one trial, but there's others and other meta-analysis that looks at that. On the other hand is the nice data that you looked at, how early should we be intervening these patients? So the question starts now, should we actually be offering AF ablation as first-line therapy to some large population or not? And as you know, early AF will be presented at the AHA, and I know the results, but I can't tell you. But this is something that we should be moving towards. And how do we actually manage this information and introduce it in? How can we manage the availability of time that we have currently for different procedures within our system?
As you highlighted, yeah, this is a really hot topic and emerging area of interest, especially because of the publication of the EAST trial, which I think is going to be discussed at EP rounds tomorrow morning. For those of you who aren't up to date with the EAST trial, it was a trial comparing early intervention, an early rhythm control strategy with standard of care. And EAST did find a benefit in terms of hard cardiovascular outcomes where, the earlier you intervened on AFib, patients did better. And this is something that I've been interested in quite a bit with Dr. Piccini, who I've been doing this work with at Duke. And one of the next steps that we're going to try and do is use input or design a new cost or decision analysis using some of the work that we've done, looking at diagnosis to ablation time, some inputs from EAST. I guess we could wait for early F2 and try and figure out, the impact of, timing on AF outcomes, as well as, there's some more complicated economic modeling, discrete event simulation, where we can actually model out wait times and procedural times and cath lab flow to try and understand, the system impact in terms of, increasing the volume of AF. So some stuff to come over the next year that we'll work on.
Great. I think there's some other questions there on the chat. Before you go to one of those, I've found fascinating the variation of care for AF across the province. So what are your ideas to try to provide more of a standardized care, and how can we actually advance that? Are we going to be doing some trying to look at practices and giving them some scores and some incentives to try to improve standardized care, or how do you think we're going to do that?
That's a great question. As we know, there's a lot of different types of AF interventions that have been tried and studied as well. Part of the problem is a lot of our research, a lot of our interventions are very urban centric. And so I think ultimately we want strategies to reduce this inequities. But what we need to do as the next step is to really understand the factors of this practice variation and what are the factors that are unique to more rural, northern regions in Alberta. And depending on those determinants, then to design strategies to address them. And, it could be to have, centers of atrial fibrillation excellence, as described by that recent white paper in the Heart Rhythm Journal. It could be, an increased spread of telehealth. It could be leveraging Alberta's or the EPIC system when it comes around to provide electronic support decision tools for primary care providers. There's lots of possibilities, but once again, it comes down to what are the specific determinants that we find as the cause of our local practice variation.
So Derek, Sarah has chatted in a question. She wants to know your thoughts on using individual practice pattern data from individual physicians to drive change. So something that would align with the specific individualized physician learning program.
it'd be great if we could move towards something like that, and not to use, physician outcomes, physician quality as a stick, but just as, a gauge where, like, here's what your practice looks like. Here's what the average practice looks like in Alberta. This is what other similar clinicians are doing. Either a good job or, try and change your practice, kind of an internal motivation. Unfortunately, we don't have the automated system and dashboards yet to do something like that. And I think we should. We'll get there. I know there's a lot of interest in better integrating cardiac data at the Center for Health Informatics with Hudi Kwan's group. And, I think this is an important way to motivate change at the provider level.
Can I ask a question?
We would be honored.
Too kind. The ultimate purpose of this kind of research, of course, is to change standards of practice. And when that costs money, it becomes a political event. Whose job is it to take this data to government and say, for example, the use of NOACs instead of warfarin in atrial fibrillation not only is cost effective, it saves money, yet the drug is not covered in Alberta because it would require a transfer of funds from one silo to another silo. You've heard me rant before that the drug is available in Quebec thanks to our transfer payments, but that's a different issue. The question that I have is, okay, we got great data. It's going to cost a bit of money. Who convinces the payers that this must go forward?
You touched on a very important point where health economics and health policy are intertwined. And, it's not, doing all this research, that's great and all, generating the evidence, that's fine. But really, that link, taking this toward government, that's the key part. And the nice part is Calgary does have those networks of health economists, outcomes researchers with ties in the SCNs and AHS to try and motivate and advocate for better patient care pathways and funding models for medications that actually make sense. And our hope is that with all this data, and especially making an economic case, people can understand dollars and cents, perhaps less so patient outcomes, but hopefully if we make an economic case that governments or next governments will listen.
Just thank you. As a follow-up question, in that regard, the politics of the kind of research you're doing make the base assumption that the funding envelope is capped. I remind you that the FAA, the Federal Administration of Avionics in the United States, considers it appropriate to command a change in aircraft technology with a cost savings or quality adjusted life year gained of $1 million, never mind 100,000. I know there was no question there. You don't need to answer it, but good job, by the way.
Thanks, Dr. Mitchell.
Derek,
maybe Brent needs to go for Minister of Health, and that's how we change things.
There's a question on the chat from Jargon. It has to do with the robustness of some of the modeling and the Markov model in particular. And I think what he was wondering about specifically is whether these have been assessed where a Markov model was made, a change was implemented. Has someone gone back and determined how accurate the initial model was in those circumstances?
Yes and no. I mean, Alberta, we can look at, because Alberta collects all the administrative data, we can look at historical patterns to make sure that we were, estimating what we intended to estimate. But, models tend to get it wrong, or can get it wrong. Let's see if I have here. So I didn't put this slide in, but this is going back to the example of loop recorders and Holter monitors to detect atrial fibrillation and cryptogenic stroke. So these studies didn't compare the three strategies, which the two, ILR and Holter monitor. And we see that in the systematic review, the point estimates are, in the orange and red. Most estimated in ICER in the $40,000 to $50,000 range, but we see the one outlier from Cadith. And for those of you who don't know who Cadith are, they're a very, very smart group of scientists that do health technology assessment for our government. The problem with this model here, unfortunately, was that they got one input, mortality. They use a spurious input. And, that one input caused like a 10-fold increase in the ICER that they estimated. So, going back to, check models, it's not always done. It just highlights the importance of, transparency when designing these models so other people can go back and check. And, it is worth, continually reassessing various technologies to make sure that, we have a Markov model, it actually performs and does what we want it to do after a policy has been implemented. But we could do that through Alberta, which is nice.
Great.
But
Paul, I think that's a question.
can I just make a quick comment?
Absolutely.
And that is, I mean, you showed nicely that it's not a number that goes into the model, but a range of numbers and sensitivity estimates. I mean, it's just like everything else, right? It's like forest plots for clinical trials. That the inputs you put in are disclosed. They are evaluated by peer review, and sometimes they get through the process just like everything else. But I mean, the more important part, and I thought the really interesting part of that analysis was, like, for example, for TYRX, that as the price goes down, the potential cost effectiveness changes. And so I think Carlos's point is very accurate in terms of we have the capacity to negotiate lower prices for products. The challenge is that once we do that, everyone in Canada and the world has access to the data because it's public in terms of what we're paying. And that's why the companies, I think, are so hesitant to reduce prices. But this data is pretty compelling that if you reduce the price, it becomes a lot more cost effective. And the same holds true for all VEDs.
Paul?
Yeah, thanks, Derek. Great presentation. And I think your line of work is really going to be important over the next few years, particularly in our department. Value-based healthcare is going to be a major priority for us in the department. And your skill set would be very valuable for us and fits very well with a lot of our priorities. So that's really exciting, and a lot of what you touched on, I think, are really exciting areas that are worth exploring. My question for you relates to this type of work, and you've been working in a hub of expertise with this type of work with the Duke Clinical Research Institute. My question for you is, how do they translate this? So there's always a gap between generating this really important data that should help inform us and guide us clinically, but then people generally don't translate it very well or use it well. So what are they doing at Duke? How integrated is this research team and program that you've been involved in informing the clinical department, for example, and seeing actual changes in clinical department that drive value? Have you seen examples of it actually working, and what are the steps that they're taking to make that happen?
So I think there are a couple levels here. So at the local level, when I say local, there's the Duke health system level. And there's been a lot of interest in terms of the way they deliver healthcare and with technology, and improving transitions of care between hospital and the outpatient setting. That some groups have shown, okay, this is a great way to reduce readmissions and costs. And so to have, you know, a robust electronic network to, you know, collect data, collect costs, collect outcomes in, you know, what we refer to as kind of like a living health system type of model, where it's not just implementation of new policies, new interventions, and we just kind of like hope that it works, but that continuous evaluation piece, and then using the results of that evaluation to inform, you know, tweaking these implementation models. And so it really comes down to comes down to data and how much access we have to data, and is this data in real time, and can we analyze this to, you know, improve the way we deliver care at a more rapid pace.
Do you find, you know, at Duke, do you find that they're incentivized to do this? Because the problem is that a lot of times in research, our metrics are, we want to publish in great journals, we want to get lots of citations, we want to get lots of grant money, and, you know, we want volume of publications, but do we actually use the research that we're developing? So have you seen anything in place where, you know, they've tried to incentivize or make this happen in any special way, or is this sort of research group?
As you know, from your time in the U.S., like the incentives at the higher level from administrative and hospital are quite different than here, where, you know, quality metrics are collected, and, you know, hospitals and are gauged based on how they deliver care and their outcomes, as well as their reputations at stake. And, you know, I think there's interest in integrating data to try and make sure that, you know, Duke is, you know, one of the highest achieving hospital systems in the province, just because of, you know, peer pressure, your reputation, and published metrics of quality. I guess not so much a sister institute, but important institute that collaborates a lot with Duke is the Margolis Center for Health Policy. And their pure focus is on the health policy side to take this research and advocate at the federal level with FDA and, you know, both the state and the White House. The one careful thing that I guess is a bit unusual in the States compared to, you know, European countries is that they can't use the ICER in terms of health policy decision making, in the sense that it can't be just about the money, whereas, you know, European governments have been a bit more flexible in terms of, okay, well, it's not just clinical outcomes, but we can actually take the costs to inform policy and direct, you know, pricing medications and therapies.
Okay. Thanks very much, Derek. Look forward to chatting with you later today.
Thank you. Look forward to chatting as well.
So Derek, that was wonderful. It's just about 9 o'clock, so I'm going to use this opportunity to thank you for sharing some of this knowledge with us. It's clearly very important in what we do now, and I suspect it's only going to be more so over the next decade or so. With that, I hope you enjoy your time in Calgary, despite all of the current pandemic precautions. Thank you.
Thanks for having me here.